Today we're going to talk about cervical cancer. Well, cervical cancer is primarily caused by infection with the human papillomavirus, or what we call HPV, which is the main risk factor. So, primary prevention of this cancer involves vaccination against the most frequent applicated HPV types, particularly HPV 16 and 18, which are responsible for the majority of cervical cancer cases. The natural history of cervical cancer is characterized by a long period between the initial cellular transformation and the development of an invasive carcinoma or cancer, averaging around 30 years, though it can range from 10 to 15 years. This prolonged transformation period provides a window of opportunity for early screening, making this cancer particularly accessible to secondary prevention. The Pap smear or a cervical cytology test is the most commonly used screening tool, allowing for the detection of cellular abnormalities before they develop into an invasive cancer. This enables preventive interventions to stop cancer progression. Screening also includes HPV genotyping tests and clinical examinations, which help identify early lesions that can be treated before they evolve. When it comes to positive diagnosis of cervical cancer, it's based on clinical signs, a physical examination, and endoscopic tests such as colposcopy, and of course histological tests. The treatment of cervical cancer mainly relies on surgery, with procedures such as conization or hysterectomy, depending on the stage of the disease and the patient's condition. Based on the diagnosis results, additional treatments such as radiotherapy and chemotherapy may be considered. When it comes to prognosis, it is largely depends on the early detection of the disease. The earlier the cancer is diagnosed, the better the prognosis is, emphasizing the importance of regular screening and the early identification of precancerous lesions. The diagnosis of cervical cancer is based on a combination of clinical symptoms and paraclinical examinations. While symptoms vary depending on the stage of the disease, in early forms, the discovery is often accidental, either during a screening Pap smear or what we call cervical uterine smear, or during a colposcopy performed for other reasons. Metrorrhagia or abnormal bleeding, often after sexual intercourse or spontaneously, may be a sign. Pathological leukorrhea or the presence of abnormal vaginal discharge, often associated with infections, may also be another sign. In more advanced stage, signs of invasion of surrounding structures may appear, like some urological complications like pelvic pain, hematuria or blood in the urine, renal failure or anuria, meaning the absence of urine production. Rectal bleeding and abdominal pain may also occur, related to the invasion of the rectal area. Swollen leg or massive edema, often due to metastasis or obstruction of lymphatic vessels, can also be another sign. In addition to these local signs, general signs may include unexplained weight loss, persistent fever, anemia, or other symptoms, which may be related to chronic bleeding or other causes. This cancer can sometimes be discovered during a metastatic workup. Age is a determinant factor. Cervical dysplasia, which can progress to cancer, generally occurs around the age of 30, while invasive cancer appears on the average at 45. The patient's medical and surgical history, including surgical intervention, gynecological conditions, or treatment received, helps guide the diagnosis. And the risk factors for cervical cancer mainly include HPV infection, as we said before, particularly types 16 and 18, which are responsible for most cervical cancer cases. Other risk factors include early and unprotected sexual activity, a high number of sexual partners, and smoking. States of immunosuppression, for example HIV infection, corticosteroid therapy, can increase the risk of cervical cancer due to decreased immune system efficiency. Multiparity or having had several pregnancies can also be a risk factor. Although the role of genetic factors is not fully understood, certain hereditary predispositions may increase the risk of developing this cervical cancer. Now let's jump into the clinical examination. During the speculum examination, if the cancer is microinvasive, the examination might appear normal. However, in the most cases, the tumor might appear spotting, friable, or articulated that bleeds easily upon contact. The base of the tumor is usually hardened or undulated. It is also essential to look for any clinical signs of invasion in the vaginal wall. Vaginal examination aims to detect any masses in the cervix or tumors that bleed easily. It is essential to palpate the vaginal walls, including the anterior, lateral and posterior, and the 4 vaginal fornices to detect any possible invasion. Biodigital examination is performed to assess the recto-vaginal septum, and rectal examination is used to explore signs of invasion of the parametria or rectum, and the general examination helps evaluate the patient's overall condition and detect any systematic signs such as any lymphoadenopathy which may indicate metastasis. When it comes to paraclinical examinations are very essential to confirm the diagnosis and assess the extent of the cervical cancer. A biopsy is crucial for confirming the diagnosis. It allows the collection of the tissue sample for laboratory analysis. Histology determines the degree of the tumor invasion, which help assess its aggressiveness. Immunohistochemical techniques are sometimes used to differentiate cancer of endometrial origin from those arising from the endocervix, as they can present with similar clinical form. And pelvic ultrasound is performed either transvaginally or transrectally, which allows the evaluation of tumor size and local extension. It also enables the visualization of the adnexa, bladder and rectum to detect possible metastasis or neighboring invasion. When a body lesion is observed on the cervix during speculum examination, several conditions should be considered in the differential diagnosis. These conditions can mimic cervical cancer due to the presence of similar lesions. First one, cervical polyps. These can appear as pollen masses but are benign. Syphilitic chancre can cause an ulceration similar to cancerous lesions. And cervical fibroid, which is a benign tumor often mistaken for malignant tumor due to its shape and appearance. A large neighbored cyst, which is a metaplasia where the glandular epithelium is covered by squamous epithelium, creating cysts on the cervix. This condition must also be considered in the differential diagnosis. Finally, endometriosis can also present as lesions on the cervix, but they are usually localized and have a different appearance from cervical cancer. After the positive diagnosis, the FIGO clinical classification is used to determine the stage of cervical cancer. It is based on clinical examination and resuscitation and serves as the reference for therapeutic decision making. Cervical cancer is classified into several stages, from stage 1, where the tumor is limited to the cervix, to stage 4, where cancer has spread to other organs like the bladder or rectum. Each stage is further divided into subcategories A and B to better describe the local and regional extents of the disease. The main objectives of the treatment are to eradicate the tumor, improve patient survival, prevent any recurrence, and address the patient's psychological well-being. Surgery can involve conization, which removes the part of the cervix affected by the tumor. In more advanced cases, a total hysterectomy, complete removal of the uterus, may be performed. A more radical procedure is the extended colpohysterectomy, which also includes lymph node removal. For locally advanced tumors, a pelvectomy, anterior, posterior, or total, may be performed to remove affected tissues and organs in the pelvic region. Radiotherapy, used to destroy cancer cells, can be administered as uterovaginal brachytherapy, placing radioactive sources directly in or near the tumor, or as external beam radiotherapy, directing rays toward the affected area. Chemotherapy, depending on the type and stage of the cancer, it may be used alone or in combination with surgery and/or radiotherapy. Cervical cancer screening is primarily based on the pap smear. It is recommended for women aged 25 to 65 years. After 2 negative pap smears spaced 1 year apart, screening can be performed every 3 years. In the case of an abnormal pap smear, diagnostic investigations must be conducted based on cytology results to evaluate the presence of precancerous lesions or HPV infection. HPV vaccination is based on 2 main types of vaccines. Bivalent vaccine protects against HPV type 16 and 18, responsible for the majority of cervical cancers. Quadrivalent vaccine also protects against HPV types 6 and 11, which often cause genital warts. Vaccination is strongly recommended for girls aged 14 to 15 years, before the onset of sexual activity. It can be administered up to 23 years, provided the individual has not yet had sexual intercourse or at the latest 1 year after sexual debut.